Ventilation rate should be 100 to 120 per minute. Depth should be 5 to 6 centimeter. Allow full chest recoil. Minimize interruptions in between. Avoid hyperventilation. Now let's talk about the special situation in case of the resistant VT, ventricular flutters or torsades de pointes. In patient with resistant monomorphic VT or polymorphic ventricular tachycardia or ventricular flutters not responding to other drugs mentioned above, the following drugs should be tried. So we need to use propranolol 1 mg IV bolus to be repeated every 5 minutes up to 3 times if necessary. Total dose 3 to 5 mg of propranolol should be used, or we can also use metoprolol 2.5 to 5 mg bolus over 2 minutes to be repeated every 5 minutes for 3 times if necessary. So total dose of 15 mg of the metoprolol should be used. So talking about using calcium, though not routinely recommended for treatment of cardiac arrest due to VF or pulseless VT, may be tried in patient with resistant VT due to hyperkalemia as a triggering factor. When hypocalcemia is suspected or patient have toxic effect of calcium channel blocking drugs, infuse 10 ml of 10% calcium gluconate at a rate of 2 to 4 ml per minute. So after talking about the shockable rhythm, ventricular fibrillation or pulseless ventricular tachycardia, we are now going to talk about the non-shockable rhythm, that is PEA, pulseless electrical activity or asystole. So in this case, we need to start high quality CPR immediately, push hard and fast 100 to 120 per minute, allow full chest recoil, give epinephrine 1 milligram IV or IO, repeat every 3 to 5 minutes, secure airway and give oxygen, and try to avoid hyperventilation. Previously, we also used 1 dose of vasopressin 40 unit intravenous to replace the first or second dose of epinephrine. But nowadays, vasopressin is not used according to the AHA guideline 2025. So vasopressin is not used as per the recent guideline of AHA. Check rhythm every 2 minutes, and if rhythm becomes shockable, switch to defibrillation protocol. Always search for reversible causes 5H and 5T. These are hypovolemia, hypoxia, hydrogen ion or acidosis, hypo or hyperkalemia, hypothermia, and tension pneumothorax, cardiac tamponade, toxins, thrombosis or thrombosis of the coronary or thrombosis of the pulmonary origin. As per the recent update of the AHA guideline 2025, temporary pacing is not recommended for asystole or PEA because pacing does not improve survival in cardiac arrest without pulse. Temporary pacing is only used in sympathetic bradycardia with a pulse, not in cardiac arrest. So remember this line: no pulse means no pacing. Pulse present, pacing may help. The role of sodium bicarbonate in the cardiac arrest. So according to the AHA guideline 2025, sodium bicarbonate has no role in the arrest patient. Use sodium bicarbonate only if there is severe metabolic acidosis, hyperkalemia, tricyclic antidepressant overdose, prolonged cardiac arrest with adequate ventilation. So dose is 1 mEq per kg IV given slowly. Never delay CPR or epinephrine to give sodium bicarbonate. So in PEA or asystole, CPR first, epinephrine early. Fix the cause, not shock, not pacing.